Hey guys, Angela Cornelius and Matt Willens coming back to you with another endocrine bomb. Woohoo! So like we did in the last couple of series, we're going to review a case and then just talk through it and kind of, the things, signs and symptoms that the patient have. What is it making us think, right?
Yeah.
Case 4. You are dispatched to a 78-year-old female who is having generalized weakness, twitching movements of her tongue, and jerking movements of her lower extremities. Her vital signs are a blood pressure of 115/83, a pulse rate of 55, a respiratory rate of 18, and her body temperature is 96.9 degrees Fahrenheit. Further history. A 78-year-old female was being visited by her family when they noticed twitching movements of her tongue and involuntary jerking movements of her lower limbs. They were concerned she was having little seizures, as she seems to be a little slower to respond than usual. She says this and generalized weakness have been going on for about a month. She also reported intermittent diffuse headaches, loss of appetite, and an unintentional weight gain of 10 to 15 pounds in the last 6 months. She has also felt unusually cold over that past month. The patient denied any sudden onset severe headache, numbness or tingling, vision changes, any speech or gait abnormality, or any recent memory loss. She does report frequent UTIs and upper respiratory infections that she just can't seem to get rid of. Her past medical history is hypertension, hyperlipidemia, and depression. Surgical history is a left total hip replacement. Her physical exam reveals tongue fasciculations and bilateral lower extremity myoclonus. Her finger stick is 37 milligrams per deciliter.
So what differentials do you think is going on with this patient now?
All right, so y'all know me, starting from the top. I'm seeing this tongue twitching and I'm seeing this extremity jerking, right? So,
A seizure?
well, right, I'm thinking something neurologic, right? Like a seizure? Is it a stroke that's just in one area causing a little like partial seizure? Do they have a brain tumor, right? Always dun, 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 the thing we're worried about. Thyroid, right? Moving down the body. Thyroid causes all sorts of weird stuff. And so weird twitches can be coming from hyperthyroidism. But she's not tachycardic. So I would probably move that down the list. Although being a little older, she might be on a beta blocker, which might be blunting that. So you have to kind of think about that. So generalized weakness, right? That always throws in like cardiac syndromes, right? ACS in particular. And then this tachycardia and these twitches, is this actually alcohol withdrawal? You always got to think about that. In some of our patient populations, it's pretty common. And then electrolyte abnormalities, right? Has she maybe gotten dehydrated or for some reason had acute kidney injury? So that can definitely make muscle twitches. Or is this just benign tremors? And when you actually get into the history, she's actually had this for months or years.
So what kind of questions do you want to ask this type of patient?
Okay, so again, I always start with past medical history, right? Is there something that's already been diagnosed? Why do I need to reinvent the wheel if they've already been diagnosed with something? It can definitely help with figuring this out. And then, does she have a history of seizures, right? That could very well be part of this. Surgical history, but in particular with these symptoms, like, did she have anything going on up in here? Did she have a craniotomy for something, a Chiari malformation maybe? Any other neurologic symptoms, right? Has her vision changed? Has she noticed like one side of her mouth maybe droops a little bit, one arm's a little bit weaker? I don't know. Thyroid stuff, cancer, recent infections, alcohol use, right? I want to know her social history, particularly alcohol. What's been going on in the last couple of weeks? Anything new, anything different that may have brought this on? And then, of course, for like ACS, I want to know chest pain, shortness of breath, dyspnea on exertion, paroxysmal nocturnal dyspnea when they lay flat and they feel like they're drowning. And then, does she have any history of benign tremors? Heat or cold intolerance? Again, like a lot of these things overlap.
A lot of them look like they're the same.
Yep.
So what does this change in your differentials?
So with no other neurologic complaints, that's going to make stroke way lower on my differential, right? Still there, but way lower. The headaches, though, And the pattern makes me more concerned about something growing in her head, some sort of brain tumor, right? No history of thyroid disorder. And you combine that with the weight gain, makes hyperthyroidism less likely. Because generally hyperthyroidism is like internal speed. And so like it speeds everything up and patients tend to lose weight because their metabolic rate is increased. Hypothyroidism, generally not associated with muscle twitches, again, because hypothyroidism, I misspoke, hypothyroidism, generally not muscle twitches, because it tends to slow things down. But she does have the weight gain and the cold intolerance, so like that's up my list a little bit. No chest pain, no shortness of breath, no dyspnea on exertion. That's going to move ACS way down my list. Like I'm probably still going to like throw a troponin and an EKG on in the hospital, but it's not near as concerning to me. So it's interesting. She seems to have a lot of symptoms that are coming from a lot of different areas on her body, right? So what is her blood sugar, right? Because I'm always looking for something. Occam's razor said you find the one diagnosis that makes sense for all the symptoms, and that's the most likely one.
Yeah. So, so what does this make you seem that's going on? There's a lot of differentials, a lot of different symptoms, but trying to put it all together to make sense out in the field could be really confusing.
Absolutely, absolutely, right? You've got symptoms of a lot of different things together, which makes you think, maybe this is something more central, right? So she's got thyroid symptoms, she's got low blood sugar, she's got fatigue, she's got headaches, and she's had frequent infections. So again, what can tie all of these things together? So lack of the adrenal gland hormones can explain the low blood sugar, the frequent infections, right? Because we talked in the other session where we were looking at Addison's disease about the adrenal hormones. So that kind of makes some sense here. But she's also got hypothyroid symptoms, right? Well, the thyroid hormones don't come from the adrenal gland, so that doesn't make a huge sense. But what connects these two glands together? Right? So both of these glands are downstream in the hypothalamic pituitary axis, right? So maybe we need to go more central. So the hormones from the thyroid gland and the adrenal glands are actually stimulated by hormones that come upstream in that axis.
So taking a look at the HPA axis and talk through this, can you explain that a little bit to us?
Sure, absolutely. So this is all kind of very much more intense, but let's look at the axis. So at the top, you're going to see the hypothalamus, right? So it sits right under the brain, and the hypothalamus is the part of the brain that ties all the endocrine system together, right? It's sort of like the central powerhouse. It also ties the nervous system together also by way of the pituitary gland, right? So that feeds all into the pituitary gland. So when the hypothalamus senses changes, it sends neural stimulation to the pituitary gland. So the anterior pituitary puts out your TSH, right? So it's going to turn up your thyroid. It's also going to do LH, FSH, which are some of your sex hormones, and adrenocorticotropic hormones. So that leads to thyroid hormones, sex hormones, cortisol. So there's also stuff, that goes to the posterior pituitary, which is going to release antidiuretic hormone, which is going to go to your kidneys, and some of the vasculature. So that's going to lead to increased water absorption, vasoconstriction, so those type of things.
Let's say your pituitary gland controls a lot.
It does.
And it seems like when you start to see that issues with that is when everything gets thrown off.
Absolutely, absolutely. So if you lose your pituitary signaling, you lose all or some parts of these hormones, which just kind of makes sense. Like if you're seeing it from multiple different endocrine things, well, then maybe it's a central endocrine thing. So, with loss of TSH, you're going to have low thyroid hormones, which leads to low metabolism, bradycardia, hypothermia, hypotension. And then indirectly, from the thyroid hormones not being there, those thyroid hormones affect the catecholamine receptors in the heart, right? So now you're looking at more depressed cardiac function. And then LH, FSH, also going to be gone in part, maybe all. So you're going to have some gonad dysfunction. So that might not be noticed at all in an older female or an older male, but in a kid, like that's something you're going to notice, right? And then lack of adrenal corticotropic hormone is going to lead to low levels of cortisol, which leads to decreased immune system functioning, decreased metabolism, so increased illnesses, right? These are going to be the people that are just sick all the time. They catch everything. Somebody walks through the building on the other side with an illness, and they're going to get it. And then they're just weak and fatigued, just kind of in general. Also, right, pituitary also puts out ADH. Which is antidiuretic hormone. So you're going to have decreased water reabsorption. You're going to have dehydration from that. So you're putting out a lot of pee that's very, very clear. Electrolyte problems also. Hypernatremia, well known that this happens with that. This particular case is also known as diabetes insipidus when you see this. So these are those patients that are just peeing tons, and we have to keep replacing their electrolytes because they're basically peeing out all their free water.
So all that's really starting to make sense for me, but why would all these symptoms cause the muscle twitching and things like that?
Okay, so like we talked about, muscle twitching can be caused from electrolyte abnormalities, which we just talked about all the electrolyte abnormalities this can cause. But there are theories linking the TRH to hyperreflexia. So it's kind of interesting that this particular hormone can play either a stimulatory or inhibitory role in the brain, depending on where it's at. So really some kind of cool stuff. And they think a high level of TRH can be expected in central hypothyroidism, and it might be that it's activating these areas of the brain, causing these hyperreflexia, myoclonus type events. So it's kind of cool, right? Love science. It's supported by the fact that exogenous glucocorticoids and thyroid replacement decrease these TRH levels, right? So that's thyroid releasing hormone. I don't think I said that earlier. So that's kind of an interesting, oh wow, so that's a hormone doing something that we wouldn't expect it to do, but sometimes they do.
All this can be very complicated and honestly confusing to me. Can you just really sum up all this stuff?
All right, so anterior, posterior pituitary, put out hormones, stimulate stuff downstream. If we lose those hormones that are stimulating the stuff downstream in the adrenals and the thyroid, we see signs and symptoms of loss of that stimulation, right? So we're going to see signs and symptoms of loss of adrenal hormones. You're going to see signs and symptoms consistent with Addison's disease or adrenal crisis, maybe even. And then you're going to see hypothyroid symptoms as well, right? So the fatigue, maybe the excessive coldness, maybe they have diabetes insipidus. So it's when you see more than one endocrine thing together, you got to start thinking more of a central source like a pituitary issue.
If you end up having like a tumor on your pituitary gland, all these things could happen, right? And you also see, I've read things where you see these really tall people. That's the cause of them being tall, is because their pituitary gland is just sending out the signals to produce growth hormone.
Absolutely, right? So we talked a lot about lack of those pituitary signaling things? What if you have too much of those pituitary signaling things, like Andre the Giant in particular? Like, he was a famous acromegaly patient, and he had a pituitary issue where he produced way overabundance of growth hormone. So yes, absolutely. Like I said, we talked a lot about lack of, but it can also happen in the reverse, where you can see like way too much of all of these hormones and have all of the opposite effects of what we talked about when we're lacking things.
Yeah.